Hola. Ah, no hablo español porque yo entiendo poco. Y una certificación que puedo obtener, sí, CPC y CRC. I can't roll my R's.
That was a question that just came in on the chat in Spanish. That was our first one, I think, in all time. Hello,
Ever in
everybody.
Spanish?
Welcome to CCO Club Webinar 29.
Yay! And before we start, I want you guys to know that I have a scratchy throat. So I will probably get choked up. And I have my mug, CCO. Oh, I don't think you can see. Oh, may have taken a lot of drinks. Okay. Can we start anytime, Boyd?
You bet.
Okay.
Go for it.
All right. So this is already our 29th club webinar. Isn't that exciting? The thing that's different about the club webinars than the student webinars that we do is that it has to do with the questions. So you provide in the club the questions or the topics or things that you want a little more information on, and then we go out and we search it. And you may or may not know that this month an article I did on neoplasms came out in the AAPC's magazine, and I got some feedback and some questions that came in. And this particular question came into the club from Sarah, and it made me think, oh, you know what? We need to do a club webinar on sequencing of oncology. Oncology sequencing, just some highlights. Now, oh shoot, I should have changed this. Critical care coding, I need that to be, can I change that real quick, Boyd? Would that mess us up?
Go for it.
Okay.
Go for it.
Gee, sorry guys, I just realized I didn't change that. But you know, we're nice and casual here. So I'm going to change this. Here I thought I was doing so good to sequencing. Let's let the spell checker fix
and then
that.
you see how we do things in the back end to create all this for you.
Yeah. Okay, now we can go back to presentation mode, and you guys are pretty awesome. But the thing that's different is that this question actually came in, and I realized we needed to do a little highlights about oncology sequencing. So the things that you have to ask yourself are the things that we usually struggle with in sequencing of cancer codes in oncology, and we're only going to focus on ICD. There are some CPT things that we would do, even PCS that we could do at another time, like radiation oncology and infusions in oncology, and we'll do that. I think we should, because we do get a lot of questions about oncology coding. But tonight we're going to specifically talk about the diagnosis sequencing aspects. And the main things that we're going to touch on, because I could talk forever on this, the areas that people usually struggle with are going to be primary and secondary, you know, and history of, as well as anemia and complications. Now, the thing about primary and secondary, that concept, you know, when you're just starting out in coding, can be a little confusing, but once you get it, knowing primary and secondary isn't a big deal. You just know it, right? But there is some things about primary and secondary that I wanted to highlight to remind some of us, even who've been coding for a while. History of, you know, there's a lot of talk about things like using tamoxifen. Do you still classify, say, a history of breast cancer when the patient's on tamoxifen? And the reality is, and there's been a lot of people that have given opinions on this, tamoxifen is more of a preventative medication. So the breast cancer could be eradicated and everything, but it kind of suppresses and makes it so that if they have found statistically, because of coders, that if they use the tamoxifen for like 5 years on certain types of breast cancer, they're less likely to have a recurrence. Okay, so it's not necessarily that they're actively treating the breast cancer, they're preventing it from coming back. That's kind of that's what's different about tamoxifen. So, you know, you may have some that have in their compliance protocol that no, we're not going to say it's a history of breast cancer when they're on tamoxifen, and others will say that they will. You know, they'll say it's a history of breast cancer, and we're not going to use that. We're not going to talk about that. There's another little scenario that we're going to use. So do know with me saying that if you are in an area, inpatient, outpatient, you know, there may be protocols or reasons why you code a certain way that may fall into that gray area of your guidelines. And keep in mind, not only do we follow the guidelines and we're thinking about the payer aspect and stuff, but we want to always know in the back of our mind, you know, statistics is the reason we do what we do. And for outpatient pro fee and stuff like that, the diagnosis code doesn't carry as much weight. Right? So you think, well, I'm coding wrong. I'm going to get audited. I'm going to get in trouble if my boss tells me to code one way and I use a diagnosis code and I think it should be sequenced differently. You know, diagnosis codes aren't revenue based in outpatient coding. They show medical decision making. So, you know, you want to follow the guidelines, but in that scenario, just take a deep breath and say, okay, if they want me to code it this way, they've got it in their protocols, so my head's not going to roll, right? I'm doing what they tell me to do because this is in their compliance manual. This is the way they want it done. And you'll be fine. And then if they get called out on it, they'll make adjustments. You know, you can give your opinion and everything, but don't just say, I'm going to leave my job if they don't, you know, if they make me code this way, because it's not really all about that in ICD for outpatient. Inpatient can be a little bit different because you're getting reimbursed based on the diagnosis codes. And so they will have protocols and things in place. I do know that someone recently had asked a question about, you know, they wanted me to put down the codes, but the rest of the assessment and all this other stuff wasn't done. But it was really a stepping stone. It's not like they were actually going to bill out. You know, so there was some talk about that on one of the forums. Again, in regards to history of, we'll talk about it more in depth, but that is one thing that there's always confusion. Anemia. Whenever you have a patient that has cancer, they'll have things. They get dehydrated, they get sick, they get nausea, vomiting, et cetera, et cetera. But there's and there's the guidelines tell you how to code all of that. However, anemia is unique. There are some specific guidelines towards anemia that changes sequencing. And so we're going to bring that up to your attention and see if we can kind of paint a clear picture on that. And then complications. Whenever you have complications of, is it a complication due to cancer? Is it a complication due to the therapy that you're getting, the treatment, and how we code that? So these are the questions that we're going to discuss, the topics within sequencing oncology. There is a whole lot more than this, but these are the ones that I picked to talk about tonight. Now let's just kind of do a quick review of the basic terminology, because we're talking to people out there that are new at coding, and then we also have people that have been coding for a while and may even be in oncology. So let's do a little refresher and bring some highlights. Of course, malignant means that it's cancer and that it's the type of cancer that wants to go somewhere. That's the way I think of malignancy. Doesn't mean it has, it just means that it has the ability to. Okay, whereas benign, it grows, it can be a problem, it's got to be removed, but benign tends to not be life-threatening, it doesn't move, it doesn't metastasize, okay? Cancer in situ is encapsulated. If you have cancer in situ, I would say if you want to get one of these cancers, that's the one you want to get. Cancer in situ actually doesn't risk adjust, because usually when they get it out, A lot of people describe it as like a little jelly bean. Once they get it out, you're usually good, okay? But you have to keep in mind that once you have a cancer cells in the body, no matter what type of cancer cells, it's almost like your body's already learned how to mess up. This is now, again, I'm just telling you how my brain thinks. So cancer cells have already occurred. They could occur again, right? But cancer in situ, or CIS, doesn't metastasize. It's not benign, right? So we would say it has the malignant cells, although it's encapsulated. It doesn't go anywhere. And then we have uncertain histological behavior. More or less just says, hey, we don't know what it's going to do. This is a type of cancer that is, malignant, benign, it could go either way. It could turn into that, but we just really aren't sure. Then we have primary and secondary. Now, with benign, you're not going to have primary and secondary, because primary and secondary is only used when you have metastasis. And so malignant cancers can be primary or secondary. Primary isn't necessarily the first cancer that they find. The primary indicates the original site of the cancer. So if you have breast cancer and they later find out that you have lung cancer, and they find the breast cancer cells in the lung, the primary site of cancer is the breast, and the lung is secondary because it metastasized to the lung. Okay. However, if they found the lung cancer first, so they go in, they find a neoplasm or a tumor in the lung, they biopsy, and it's breast cells. What does that tell them? This person has breast cancer. So they go in, they find the breast cancer. The breast cancer is primary, and it metastasized to the lung. It doesn't matter which one was found first. It has to do with the histology of it. It has to do with the cells, right? So that is going to be documented for us. And that's where you get a little confused. Some confusion comes up with new coders. The verbiage primary and secondary doesn't mean first and second found. It has to do where it originated at and where it metastasized to, where it moved to. You could have two primary cancers. You could have breast cancer and lung cancer, and one of the cancer had not metastasized to the other. You get more of this knowledge and talk when if you go in and you learn tumor registry and stuff, but it has to do with the cells. Then history of, again, already highlighted a little bit about that, so we'll talk about that more in depth. But our understanding as a coder is a history of means, in regards to cancer, there's no more cancer there. It's been eradicated. There is no more treatment to that site. But the key thing is a person can be a history of, and then the cancer come back, right? We need to be very careful of the documentation, and it gets very confusing when we want to always code to the highest specificity. Then another area in malignancies that is overlooked, I think, a little bit, is when you have that primary malignancy with overlapping sites. Ultimately, what that means is that you have the cancer in more than one place. It hasn't metastasized to another organ, right? The example here that I gave you is C34.8. So we have cancer that's in the bronchus and the lung. Now, you say, well, that's lung cancer. Well, it is lung cancer. That's the organs of the lung. However, it's overlapping into the bronchus and the lungs. We have codes for cancer in the bronchus, and we have cancer in the lung. We have cancer in the upper the lobes and so on and so forth. So we want to make sure that if it is documented that it's overlapping, and it's not probably going to say overlapping, okay, that we code it with a 0.8 code. So you can go in and find a code for cancer of the lung, which is probably going to, it's like C34.2 or something, or O, I can't remember. And that would be, say cancer of the lung, and then you might have cancer of the bronchus. Let's say, for me just guessing, that, 0.0, C34.0 is cancer of the bronchus, and C34.2 is cancer of the lung. But whenever you see a 0.8, okay, C34.8, that is an overlapping code. Right? You're not going to see that very often, but it does exist. And that should be a giveaway for testing purposes and for making sure you get to the highest specificity, right? We're doing statistics, not just to get paid. And we're not going to list cancer of the bronchus and then also cancer of the lung when the provider tells you that it's the same cancer that's overlapping there. Then it's C34.8. So remember, 0.8 equals overlapping when it has to do with your neoplasms. Another area that I think doesn't get talked about a little bit would be ectopic tissue, malignant ectopic tissue. And I think the reason is whenever we think of ectopic, the first thing my brain goes to is ectopic pregnancy, right? But let's talk about what ectopic means. Ultimately, it means something that's not supposed to be there. So after you think of, that's what an ectopic pregnancy is. It is a pregnancy that gets into the fallopian tubes. The baby doesn't attach, the little fetus doesn't attach there into the uterus where it's supposed to. It attaches or stops there in the fallopian tube and starts to grow. And this can be life-threatening because it can grow, rupture, and someone could bleed out. So, and that means exactly what we were talking about. It's out of place. The fetus was supposed to be in the uterus, but it's out of place. It is in the fallopian tube. Now, let's talk about ectopic tissue. There are some other ectopic tissues that happen, like in the liver and the pancreas, gastro tract. What I think of is Barrett's esophagus. So if you have a lot of irritation of the esophagus, say because you have reflux or something, the lining of the esophagus, that tissue is not the same as the tissue inside the stomach. So what the body does is it tries to protect itself, and it ends up growing that gastric or stomach tissue up into the esophagus. Well, the problem is esophagus tissue is different. It's structurally different. It has a different purpose than the cells that are inside the stomach, and you don't want those cells growing someplace else. Now, just because this person doesn't have has Barrett's esophagus, and that stomach or gastric tissue is growing up into the esophagus, that doesn't mean that they're going to have a malignancy or cancer, but it means that they could. Ultimately, what do we know about cancer? Cancer is cells that grow abnormally. They either don't die when they're supposed to, they grow abnormally large or too small, they mass together, they mutate, they aren't in the proper shape, and they like to go places, right? That's kind of the breakdown of what cancer is. Cancer is cells that are mutants. They're mutated. So if you have cells that are growing someplace that they're not supposed to, they've already started that abnormal act, right, of doing something they're not supposed to do, and then eventually we know that irritants can cause cancer. Thus, smoking causes lung cancer because it's an irritant. And if you continue to have reflux into the esophagus, it could mutate those cells to where they become malignant. So again, ectopic tissue. Know what that is, ectopic tissue. And there's rules and guidelines that are specifically that work for those. Now let's talk about a few more. Principle. Principle does not mean primary and secondary. And some people get this confused. When we talk about primary cancer, we already know that's the cancer that's not found first, but is the primary site of the cancer, where the cancer started, the origin of the cancer. Principle means first listed. Which one are we going to code first in sequencing? Principle has to do with sequencing and why the patient was seen that day. Why were they seen? Were they seen if they have cancer, lung cancer and breast cancer? Is the reason they were seen that day the lung cancer or the breast cancer? Right? That's the principal diagnosis, the one that's being treated that day, the one that you're going to list first. It's principal, just means first. And also, we need to talk about immunotherapy, chemotherapy, and radiation therapy. Now, most people know chemotherapy. Chemotherapy, actually, if you take a Tylenol, you're practicing chemotherapy. You're putting a chemical in your body. That's chemotherapy. Although chemotherapy with cancer is associated to the medications that are infused into the body to kill the cancer. And so whenever you say chemotherapy, everybody thinks cancer. Radiation therapy is that targeted radiation to shrink a neoplasm, a tumor. And then immunotherapy is often overlooked, or maybe we don't think about it as much, because immunotherapy is different than chemotherapy. You can have immunotherapy and chemotherapy at the same time. What makes immunotherapy different from chemotherapy? Chemotherapy is putting a chemical into your body. Immunotherapy is boosting the immune system. And one of the ways that they do that is they may harvest some T cells. They, do some things to the T cells and they put them back in your body. Okay, that's immunotherapy because they're not putting a chemical in the body. We're putting T cells into your body, which are not chemical. They are like enhanced superheroes of your immune system being infused back into the body. Certain types of cancer react very well to immunotherapy, like blood cancers, like leukemia. Okay, and so we would be boosting the immune system to help the body be stronger and fight the cancer, the blood cancer. Whereas chemotherapy, we're killing cells, and you end up killing good cells and bad cells. With immunotherapy, you're not going to have, you still have signs and symptoms. I mean, it feels like you can get the flu symptoms and things like that, but you're not going to lose your hair. So with chemotherapy, a lot of times the cancer, you're fighting fast growing cells, which would be like the lining of your mouth and mucosal membrane, your hair. And so that's why people lose their hair in chemotherapy. You're not going to lose your hair with immunotherapy. You're boosting the immune system. Okay, now that we know all of that, let's talk about the documentation. There are a few things that documentation does, and as translators, that's what we are as coders. We are translating the documentation into a code so that it can be tracked statistically, and that makes it easier for us to get paid. So that documentation the provider gives us, we can only code off the documentation that we're given. We're it's not that our hands are tied, we're translators. Okay. And if you learn anything, if you deal with people that are in the world of translation, and my knowledge of that is more in sign language. Yeah. But, even if somebody's is your translator because it's Spanish to English or German to English or whatever, a professional translator, someone that's, certified and is a translator by trade, you only translate the information you're given. Okay. So there's some funny YouTube videos and memes out there for translators, and people who use translators, because and the one I think about is that the person says one word and then the translator talks for like 2 minutes. It's like, what? Or vice versa. Yeah. So the person talks for 2 minutes and the translator says, she said good. Like, no, that's not what she said. So again, we are translating. We're translating the documentation. We can't assume. We can't practice medicine. We are taking only the information we're given and we're assigning the code to the highest specificity. So we rely on the documentation. Now, for certain types, often the provider doesn't understand the guidelines that we use. And so they I don't want to say they assume. So therefore, what's in their head doesn't necessarily get on paper for us to be able to translate. Okay. They don't paint a full picture for us all the time because the information's up here and they're thinking of another person reading this documentation that's another provider that would just know this stuff. And yet we know that if it wasn't documented, it wasn't done, all this other stuff. It has to be spelled out for us to be able to get to the highest specificity. And this is very true in oncology. So what do we need to make sure the provider knows when we inform them of the documentation that we need to be able to code to the highest specificity? He needs to know that it definitely impacts readmission rates, the research that's involved, because what do we code for? Statistical purposes. The physician's profiles, the hospital's profiles, and sometimes the third-party contracts that they're dealing with. So they really need to be able to expand the documentation to the highest specificity. And sometimes it's a matter of just adding a few words. The person's seen for anemia. Okay. The person's seen for anemia due to the cancer. Oh, that's a different code. The person is seen for anemia due to their cancer due to the chemotherapy that they got. Oh, that's a completely different code. Okay. So we have to, and then we have to know what kind of cancer they have, so you see, I've got some examples of that. And another thing that I found that was fabulous, and I put it all in the reference so you can go back and reference these sites that I got this from, is that we have to consider where the provider's coming from, as well as them considering how we read the documentation and the guidelines that we follow. And they're not taught that. But we have to remember that physicians are employed. They're employed, or they could be self-employed, they could be their practice, or they could be employed by a hospital. They could be employed by a physician group, so they're still a team. And they often have the mindset that everything that they bill is carried over to the coding, and it's not. Okay, so it's the coding that creates the billing. Again, we're coding for statistical purposes, It just happens to be a convenient way to get paid. Okay, so they are thinking about themselves getting paid, right? I need a document to get paid, which is true. But ultimately, they're documenting for better patient care, to paint the picture of the patient. And then also, they the another thing that physicians sometimes don't realize is that, I mean, part of it's because of the way that they're taught in medical school, is that, well, I only have to document why the patient was seen that day. All those chronic conditions that the patient has, that's not, it's pertinent. I know it, but it isn't pertinent to the billing, to my documentation, all those other chronic conditions. And yet they are. They, especially as we move now into the world of everything risk adjusting. And, most providers would be very hard pressed to say that a chronic condition doesn't affect what's happening to that patient that day. Now, diabetes, of course, that's a given, but even like COPD, right? You're thinking, okay, well, the patient stubbed their toe and they have COPD. It's not really going to be related. Well, actually, when you think about the disease process, they have COPD, they don't have as much oxygen, they may not have diabetes and stuff like that, but if you have COPD, you're not getting circulation as well. It's, at your extremities of the toes and stuff like that. And so, the likelihood that a person that doesn't have COPD that breaks a toe and a person that does have COPD that breaks a toe, there might be a little bit of a difference in their healing, some other complications that could occur. So we want to assist them in making sure chronic conditions are listed, especially chronic conditions when a person has cancer. The documentation we need for cancer, for ICD, is we need to know where the cancer is located at. So what's the site? Is it the lung? Is it the brain? Is it the bones? Is it a blood cancer? Is it a lymphatic cancer? Is it in the liver? Is it in the pancreas? Right? We have to have a location. We also need to know the morphology of it. So the morphology tells us, is it primary, secondary, cancer in situ? That's the morphology of it. We need to know the stage of the cancer. Now, definitely with stages, if you have an understanding of tumor registry, then yeah, that's another type of coding. It falls very close to what we do in medical coding with ICD and CPT and stuff, but it's different. So we kind of talk the same language, but there's things that they code to a higher specificity that we can't. And they need more history, more of detail, because that's all they're working with. It's almost like, it's not quite like, people in the UK speak English and we speak English in America, but not all the words translate, right? And so it's kind of like that. They use words using in codes and abbreviations in tumor registry that we don't. But if you understand the basics of tumor registry and how they write that out, it'll make you a better coder, and you can get to a higher specificity a lot of times because your provider speaks tumor registry. They have been taught to put that information in there, and that's their lingo as well. And we need to catch up if you're going to be working with oncology. So staging, we do need to know the stage and cell type. Okay. Also, another thing that's overlooked is there more than one tumor or neoplasm in an organ? So if you have a pancreas and there's 2 masses in the pancreas, the brain, if there's 2 or 3 masses in the brain, right? That is something that we need to know because it gives us a different code, a higher specificity. Okay. Very important. Will it make a difference in the billing? Not necessarily, although it does show different medical decision making. But statistically, we need to keep that. We need to keep track of that. So the example of this, some of these are of documenting to a higher specificity and the information that we need. And some of this is tumor registry stuff. And again, I encourage you to go out and learn a little bit more about tumor registry. There is a certification for that. And you can, I think you can download the training books for that certification. A long time ago, I looked into it. It was pretty cool. So this first example, if we have so it's left-sided breast cancer, IDC, grade 3, PT2, 3 centimeters in P and O, and then O out of 10, CMO, diagnosis 2000 and something. Okay, that is documentation that is amazing. So we have, so what does that tell us? That whole statement says that back in, she was diagnosed in 2000 and whatever with ductal breast cancer, grade 3, and then all of this other information is telling you the size of the tumor, about the margins, where it's located, and so on. It's pretty fascinating. So let's look at this. If the person is ER/PR positive or HER2 negative, right? HER2 has to do, is a fancy way of just saying hormonal estrogen registered positive. If you're HER2 positive, that means that the cancer is a type of cancer that feeds off estrogen. And so you want to be HER2 negative. If you're HER2 positive in the past, like about 5 years ago, that was not a very good thing. But I know that my mother had she had ductal cancer, like the IDC, and she also was HER2 positive. She had 2 different types of cancer and her breast cancer. And they said like 3 years prior to her diagnosis, they'd come out with these 2 new drugs that specifically targeted HER2 positive cancer. And it was a game changer for this cancer. And sure enough, the protocol with how she did her treatments. So if she hadn't have been HER2 positive and started these new drugs, they would have done the mastectomies and done the chemo. But instead, they did the chemo. She went 6 months on chemo, then had the mastectomies and 6 more months of chemo. When they did her mastectomies, these 2 drugs actually completely eradicated the 17-centimeter tumor that she had in her breast. The pathology report from the mastectomy said there was no cancer cells. And so that's amazing, right? And so we need to have all that documented. Next one, status post left mastectomy, SLNB positive and ancillary dissection. So they took the lymph nodes. There was, and chemo and hormonal therapy, and then they have a date. So again, we know that she was, that they did a mastectomy, plus they took ancillary nodes from the under the arm, and that she had chemo and she had hormonal therapy. Now, when you're HER2 positive, you end up getting hormonal therapy too, because you want to decrease the estrogen because the cancer feeds on the estrogen. It's like it rides the estrogen through the body. Next one, remission until found to have widespread bony metastasis, thought likely from breast primary, and then they give a date. This is really good documentation because we now know that we have metastasis to the bone. And it's not just metastasis, we have widespread metastasis. And just a little highlight that bone cancer is systemic cancer, just like leukemia and in the lymph nodes. because your bones go out throughout the entire body. Let's see, status post samarium injection, which is a type of medication given to treat the cancer. Status post palliative XRT to left shoulder and humerus. That's radiation therapy, and it's palliative. So again, you have to understand what palliative means. Now, what would not be considered good documentation? Let's see if I can say this. Pancytopenia due to chemo and disease. All right, so we don't know what disease it is. We know it's chemo, but really we need to have a higher specificity. So a better way to document it would be due to the daunorubicin and cytarabine and AML. That's those are the two drugs, and that's the type of cancer that the person has. Again, proper documentation makes a huge difference in what we're dealing with. Oh, I see a question come through. All right, let me see where I'm at. Okay, before we get to the history of, I'm going to look at this question. Let's see. It's my first time watching. Great. What type of course in the university I can take so I can be certified? I'll answer that at the end. Okay. Thank you, JM. Yes, Miss Haddock. I know that she is in our club and get information from her. Thank you. I did have an article come out in the AAPC's magazine. Okay, history of. So I already talked about it a little bit, but I just pulled this from the guidelines, and I wanted to more or less kind of put it into a layman's terms. I think it's pretty clear, but especially when we're new to this, new to coding, that history of, especially with cancer, can be a little confusing. So this is, again, just strictly from that statement, any mention of metastasis or extension, invasion, metastasis. So in layman's terms, what it's saying is you cannot use a Z85 code, which is Z85 is going to be a history code, as a secondary code, meaning that if a person, okay, my mother is a Z85. She's a Z85 for breast cancer because she has gone through her chemo. She went through, 12 months of chemo. She had a mastectomy, and the pathology report stated there was no cancer cells at all. Okay, so you have that. She actually didn't have to do radiation therapy because of that, because of the protocol, even though they told her from the beginning, even up to the time she met with the radiologist, that she would have to have it. But he said, statistics show us, because of what we've done as coders, ding, ding, that whether I give you radiation or not, because of the type of cancer that you had, the medications that you were given, and the pathology report, because you had your mastectomies after treatment had started, and we know there is no cancer cells, you have no higher risk of getting cancer again than somebody that has the radiation. So he said, my advice would be that you don't have it. And she agreed. Through all of her treatment, she was more scared of radiation than any of the other stuff, which is interesting. But she's a Z85 right now because she's not getting any more treatment for the cancer. It hasn't metastasized anywhere, and she's no longer getting treatment, even though she's taking, she has a hormone reducing therapy and some other medications that she's on. They aren't treating her cancer. They're working on ways to prevent the cancer from coming back. If you have let's say that you have a person that had breast cancer like my mother, and then they come back and they say that they have lung cancer. Okay. They are you would code first the lung cancer, and then you would code the Z85, the Z85 code saying that they had breast cancer. Okay. But there's a key to this. You cannot code them as a Z85 if the cancer in the lung is breast cancer tissue. Okay. Now because the provider states in the documentation that the cancer, it's breast cancer in the lungs and it's back. Okay. Documentation is key. And how do we know this? Because of the previous guideline that said no evidence of any existing primary malignancy. But we do have evidence of primary malignancy because there is cancer cells, breast cancer cells in the lung, right? So again, we need that properly documented, and we can query the provider if you're ever in doubt. Is the breast cancer back? And they will say yes, or they'll say no. The pathology report is showing that this is a different cancer. Then they would be lung cancer and Z85. Okay, because we need to document that they are a previous cancer patient. They've had cancer. And we do know that it's like once cells learn to be wonky and mutate, then it's more likely to happen somewhere else in the body. All right. So that is something that can be very difficult when you're starting to learn this. And again, that's why the documentation is very, very important. What about anemia? Well, this is straight from the guidelines too. I just copied and pasted them straight out of the guidelines. Okay, the key with anemia is when you're dealing with cancer and anything that the patient gets, usually the cancer is listed first, okay? And then whatever falls suit, is the patient, the patient's dehydrated. Why? Because they have cancer and they went through chemo, and they had nausea and vomiting. Okay, that dictates the way the cancer, or way everything's coded in the sequencing. But if you have anemia, and it's associated with the malignancy. Now, can a person with cancer have anemia and it not have anything to do with the malignancy? Absolutely it can. They can have pernicious anemia. They could have pernicious anemia before they became a cancer patient. Okay, there is no association there. But if the documentation associates the anemia to the cancer, the malignancy, then you're going to code the anemia. Okay. Now, first, but let's get into this a little more depth because it's a little tricky there. Notice where it says that if the encounter, the reason the patient's being seen is for the management of the anemia. Okay, so we're treating the anemia. We're not treating the cancer. We're treating the anemia. Right, so we've got to put the person in the hospital. We're going to infuse them. We're going to give them some, we're going to give them a B12 injection, and we're going to give them a transfusion. Because of the anemia, then what you're going to do is you're going to sequence the principal diagnosis is going to be first, the cancer, not the anemia, right? And then you're going to use a specific anemia code, which is D63.0, or that could be the code that you're going to pick, because you can get to a higher specificity, because we have anemia that's being treated and it's associated to the malignancy. So let's look at this. Oh, first of all, let me say, if you have anemia and it's due to the chemotherapy or immunotherapy or radiation, that changes the way you code as well. So let's look at this. If we have an encounter, the reason the patient is being seen is due to the need to treat them for the anemia, and the anemia is due to the red blood count being low due to the chemo, and just the anemia is being treated. We're not giving them chemo treatments or anything like that. What do? You code the anemia, the cancer, and then the adverse effect that it caused. And just heads up, T45 codes are probably where you're going to be at. Okay. And that's a description of that code. Right. I try to put that kind of like in a layman's term. Now, what happens if the reason they're being seen, getting treatment, is due to the anemia, due to the radiation? Okay. In this case, you're going to code the anemia, the cancer that the patient has, and the Y84.2 code, which is a code specifically assigned that, we have a problem, a misadventure at the time of the procedure. So, or we didn't have a misadventure, that we have a patient that's having complications. So the first one, we code the anemia, the type of cancer, and the adverse effect. The second one, if it's radiation, then we code the anemia, the cancer, and then the Y code. What happens if we have complications? Now, this was a really cool, and I put the resource in there. It was teaching providers the common critical complications that can occur in cancer. And so these are pretty drastic, but I wanted to show you how they divided it up. They had structural complications, and then they had metabolic complications. Now, keep in mind, this was for critical care. In other words, what type of complications would, we're putting this person in ICU. Okay. There's other complications like dehydration and stuff like that. We talk about that all the time. But I thought this would be a good idea to give you a heads up of two types of complications, structural and metabolic, that we need to be aware of, that we need to make sure that the provider lets us know if this is a complication due to the cancer. Okay. So the first one, for structural, cardiac tamponade. And if you don't know what these are, go out and do a little bit of research, but cardiac tamponade ends up being pressure on the heart. Increased intracranial pressure. So this would happen if you had a person that had a brain tumor and it's taking up space and it's causing pressure. So you can imagine all the complications that would happen there. Spinal cord compression. Now, this could be a problem if a person has a type of brain cancer lower in the brain, that the spinal cord is kind of all set in there and pressurized. So anything that pushes on that, it's like blowing bubbles. We're increasing the pressure. Right? Not good. Spinal cord compression, or it's a tumor on the spinal cord. Superior vena cava syndrome. And this is a case where that particular vessel, which is one of the major vessels that we have of our heart, that causes problems, and it'll mess up the whole body. So structurally, we got a problem. Metabolically, we have DIC, which is disseminated intravascular coagulation, and that ultimately means the blood is congealing all over. We don't have a blood clot. It's like we got soupy blood. Not soupy blood, we got thick blood. Hypercalcemia, meaning we have too much calcium in our system. Our body is chemically balanced, and if you have too much calcium or too much potassium or not enough, vice versa, the heart cannot work properly. The chemical imbalance can make you feel like you're going to have a heart attack, or it can give you a heart attack. Hypersensitivity reaction, which is anaphylaxis. So they have an anaphylactic shock, anaphylactic reaction. Malignant pleural effusion. So the lungs are can't work properly. And sepsis, of course, we know a lot about sepsis, and syndrome of inappropriate antidiuretic. So what happens is in that particular scenario, the body's been flushed out too much. We're spilling potassium, and it's kind of like being dehydrated, but so an inappropriate antidiuretic, a diuretic flushes the system, and especially when you have swelling, and then an antidiuretic helps the body retain. So it's a complication in the volume that's in the body, the fluid volume. So let's talk about a few scenarios, a couple scenarios. This is one that came in recently. She's an oncology coder and deals with this, and she had read the article and she said, hey, I got some questions because I deal with this all the time. What's your opinion? And so we ended up posting it in the forum in the club. You guys can go out and look at that. I think it's in the free forum because she's a free forum member, not a club member yet. But the question was, if you're coding a metastatic site, so that's a patient that has cancer that's moved someplace, and the patient has endometrial cancer and has gone through treatment, chemo, radiation, and had a TAH and a BSO back, she said, 2015. Now the patient returns with confirmed metastasis to the inguinal nodes, confirming reoccurrence of the endometrial cancer. She said, so you would code this C54.1 and C77.4, right? Well, the two codes she's talking about is malignant neoplasm of the endometrium and secondary and unspecified malignant neoplasm of the inguinal and lower lymph nodes. So your sequencing has to do with where the treatment is being given, okay? So if you're treating the secondary cancer, then C77 is going to go first, even though it's a secondary cancer. And but what caused the secondary cancer? C54.1. And it isn't a history code because of that confirmed, it says the patient returns with confirmed metastasis to the inguinal nodes. So the doctor's telling you the cancer's back. So this is what I wrote to them, and this will be in your notes that you can print this off if you're in the club. So first of all, the C77 would go first, and the confirmed is the key word, okay? Some people think that primary cancer can't come back, but it can, and it can come back to the site. And even like with breast cancer, even though a person has a mastectomy and they've had the breast tissue removed, and when they do that, they take like a big they take skin too, the outer breast, the skin as well. And that's why breast cancer is kind of lined in with skin, because you're taking that outer skin. Now, if a person has a bilateral mastectomies, can breast cancer occur in the breast area again? And the fact is, yeah, it can. Now, is it likely? No, because they probably got all of the tissue. But what if they didn't get all the tissue? And there's just a little bit of retained tissue, and it has cancer again, and you know, yeah, it can happen. So can primary cancers come back? Yeah. Now, an exception to this would be if a person had cancer to an area and the area was completely removed. So what would be that case? Like stomach cancer. You can completely remove the stomach, and a person can live without a stomach. So there's not going to be any stomach left. So will the cancer come back in the stomach? No, because there is no stomach. The organ was completely removed. Unlike breast tissue, where there could be some retained tissue. You know, maybe not, depends on what they remove, you know. it's unlikely, but it can happen. And also, like with stomach cancer, can you still have stomach cancer cells show up someplace else in the body? Absolutely, even if the stomach's removed, because the cancer cells were probably floating around, and it means it finally metastasized and attached itself someplace and started growing. Okay. This is why our documentation is so incredibly important. Okay. Let's see. Another one that she stated, which was really great. She said, okay, she uses these key clues that helps her determine what's going on. Okay. So again, not only is the documentation usually, it's not just super clear like we want it documented right there when the doctor says this is the diagnosis, but you have this stuff that you pull the information from if you know the type of chemo that a patient's getting and where the treatment is being directed at, then that helps you. So the example was here, patient has right-sided breast cancer. She had chemo, radiation, and a right mastectomy. 2 years later, she finds out that she has metastasis to the bone, and they have put the patient on Faslodex, and I'm not sure how to. I think that's called Zygeva, because the Faslodex treats breast cancer. We would now code this is active C50.911 and the bone metastasis C79.51. Okay, so that time I didn't grab the codes because the code itself, if you look here, this is primary breast cancer, and this is secondary to the bone. Okay. And the answer is yes, because this is active treatment for the breast cancer, right? That is our key. The documentation confirmed it. That medication is used for breast cancer, nothing else. And I even in the resources, I gave you a resource from drugs.com and printed that information about this Faslodex. Although Faslodex is different than tamoxifen. Now, I already told you about tamoxifen. Tamoxifen is used more as a preventative medication. Now, some people will say, well, no, it's active treatment. Well, yeah, it's active treatment, but it's the reason for it is so that the cancer doesn't come back. It doesn't reoccur. So whatever your compliance and regulations tell you to do is regarding tamoxifen, that's different than Faslodex because it's not a preventative drug. It is a drug specifically used to treat breast cancer. So we know the breast cancer's back, or they wouldn't put them on that drug. There's no reason for it. So you do not use a history code in that scenario. Okay? Because the guidelines tell us that they cannot be getting active treatment. And Faslodex is active treatment for breast cancer. So can you be a history code and then not be a history code for the same cancer? Yes, it can happen. And the documentation is what we go by. We need that documentation. And again, always remember that we are talking about the statistics. We're painting that picture. It's not just statistics for us. It's WHO, the World Health Organization, that's keeping the statistics. Now, I did put in there, we cannot overthink what we're being told. We can't just say, well, what if? If the doctor states that he's putting the patient on Faslodex, we know Faslodex is for breast cancer. If we doubt it, ask the doctor, does the patient have breast cancer? And then because you put the patient on Faslodex, then they're going to say yes. They may even write Faslodex is the treatment, and they may say history of breast cancer, metastasis to the bone. but it's not a history of breast cancer because it's actively being treated, even though he documented it as a history. Okay. We as a coder know that we can't use a history code if they're actively getting treatment. And what the provider thinks of as history is just saying, hey, heads up, this patient had breast cancer in the past, has it again. We need to know that's pertinent for my plan of care for the patient. And that's why I wrote history of, and then put them on Faslodex. Okay. That's doctor speak. You know, their history of doesn't fall under the guidelines that our history of definition does. So it's important that we let them know that and say, hey, by the way, now I'm not telling you not to put history up, but it would be really helpful for me as a coder. I'd really appreciate it if you would state, if you put history of, that you would also state that the patient has breast cancer. Yeah. And that's it. So any questions? And this particular person had stated, first time watching. So again, thank you very much. We have a lot of fun on these. We try to keep them kind of short and sweet. What type of course at the university can I take so that I can be certified? Well, some universities and colleges do have programs to help you get certified for medical coding. We've done several videos on this. You can look at our YouTube channel and find that. But just so you know, you don't need a degree or to take college classes to get certified. You can use our CCO Club Prime and get all of your training and become certified. A degree is not required. Okay. The other thing I would tell you about, if you're going to a university and you're already enrolled in a university and you're taking classes, you're thinking this is the career path I want, then I would look into a HEMA certification. And they have two programs, an RHIT and an RHIA, that is an associate degree or a bachelor's degree in healthcare information. And that is somewhat geared towards coding. You can end up getting one of those degrees, or the CCS. You don't need a degree to get the CCS. But we've done several videos on our YouTube channel, which are free to you. It's Medical Coding Cert, the YouTube channel, and make sure that if you go there that you push the little bell so that you can tell when we're going to do these videos. This webinar will not stay up in YouTube and on Facebook. This is a club video, and so even though you may be seeing it, once we're done, it's gone. We end up, you may see excerpts from it that Boyd chops up and does, but it's exclusive to our club members. They get to see the printout, the resources, and all that other stuff. That all being said, you definitely need anatomy and physiology. If you can take a pharmacology course, that's extremely helpful to you as well. Those would be two areas that you could take at the university that would be beneficial to you moving forward, and then taking training to get your certification. That's what I would say. And there's those resources, and there's that information on Faslodex. And I just went to drugs.com and put in Faslodex. And keep in mind too, another thing that makes Faslodex different is that it's known to treat not just breast cancer, a specific type, HER2, you know, which is that cancer I told you that my mother had. So it's a medication. It is given to treat a specific type of breast cancer. They're not using it for other stuff. I'm sorry. Anti-estrogen medication is what they're doing. Okay, that's it. Don't forget to like and subscribe if you're watching us on YouTube and Facebook. Of course, if you want to have access to all these as many times as you want to go back and reference it. If you want a print out of the handout of the slide deck so that you can go back and reference the resources, again, you need to be a part of the club. To find out how to do that, just go to cco.us/club. And you can get all the information. We have different types of club membership, and Club Prime allows you to pay an initial fee and then a monthly fee that will allow you to take a course. And you could take the PBC course, the physician-based coding course, and get the CPC, or work on a HEMO or even QPro that is out there, has several certifications. That's it. Bye, guys. I can't believe my throat actually lasted. Very excited about that.